everyone. Welcome to Doc Talks. I'm Dr. Manju George, the Scientific Director for Paltown Development Foundation, the nonprofit that supports Paltown. Today, we have the great pleasure of having Dr. Jeanne Tie with us. And before we get into the talk, let's find out how she got to where she is and how did she get interested in GI oncology and to run a trial like this.
Hi everyone. It's good morning from Australia. So I think serendipity. I when I finished my medical oncology training, I went to the lab for a few years. Just really want to learn about the biology of cancer in general. And it turned out there was a project for bowel cancer that they're looking for a student to take on, a high degree student. So it was actually a BRAF mutation in colorectal cancer. So that was my thesis actually. So I went to the lab, sequenced lots of colorectal cancer. At that time, BRAF inhibitors really just come onto the scene, as you know, with the melanoma story and the colorectal. So that's over 10 years ago. And then when I finish my lab work, it's coming out, think, where should I take on further in terms of research for colorectal cancer? And there happened to be a meeting in the US in Baltimore, it turned out, as part of the Ludwig collaboration. So the lab that I worked with during my higher degree was part of Ludwig. And Bert Vogelstein gave a talk on circulating tumor DNA. At that time, technology still, I suppose, not as advanced as what it is now. Amazing work, progress that's happened in the last 10 years. They were using beaming, show some of the preliminary data, which I'll show a slide of that later on. And it just looks like it's, out of the box thinking, very innovative. I thought maybe that blood test could have utility in bowel cancer, in particular, where we, in a scenario where particularly in adjuvant chemotherapy, where there's such huge clinical predicament at the moment. So that's how sort of we set up a little collaboration initially, just with small sample set, observational studies, and then got some really great results. And I think the collaboration just went on, and you'll hear more about the results and the trial results. So really it started from a single meeting with simple concept, and I was looking for work to do at that time. Had some time on my hand and set up this program of trying to see how we can use ctDNA in bowel cancer. And the program now is, we've got projects in pancreas cancer and also some observational study ovarian, so branching out a little bit, but focus has been on bowel cancer. And so it's really about 12 years of work from our first patient enroll onto our observational study now to the readout of the randomized trial. So hopefully I'll get to share some of that with you today.
Yeah, okay, that's great to hear. And I think I'm particularly thrilled that, that you actually started a trial and that we have results now. Because, I mean, that's awesome.
I've only just realized recently going through literature that particularly for this is really in bowel cancer, the only biomarker guided randomized trial. There has not been, even all the TNM staging that we use, risk feature that we use, and none of them have actually undergone a randomized trial to demonstrate utility. And the other thing is for stage 2 colon cancer, there's never actually been a trial dedicated to stage 2. Most of the stage 2 data comes from a combination of stage 3 and stage 2, many stage 3 trials with a component of stage 2 and extrapolating results from that. So yeah, it's very exciting, and thank you for the invitation.
Yeah, it's our pleasure to have you. Okay, so we can start with the talk.
Yeah. So I think that was my introduction slide. So there you go. So here's my disclosure. So really, I just really want to start off with introducing the concept of minimal residual disease, or MRD, which is really fundamentally why we give adjuvant treatment following curative intent surgery, particularly in bowel cancer. So MRD, or minimal residual disease, is a term used in solid tumor to describe the molecular evidence of residual cancer cells soon after curative intent treatment of the primary tumor. So with surgery and or chemoradiotherapy, particularly for rectal cancer, it can really only be detected by molecular techniques such as PCR or next generation sequencing, but not by conventional tests such as blood-based protein biomarker CEA, or by imaging. So an important clinical consequence of MRD is that if they are left untreated, these occult microscopic disease will lead to cancer recurrence, which is often incurable. So for patients diagnosed with localized cancer, the most substantial opportunity for improving survival in terms of improving cure rate is to prevent recurrence by using adjuvant therapy to eradicate these minimal residual disease. The problem, though, is until recently we don't have a test that could reliably detect this MRD, and also that not all patients have MRD after they have their definitive treatment. So for the last 90 years or so, for many years, we've really just been using pathological staging, so pathological risk feature, to infer a patient's risk of cancer recurrence. So the famous pathologist Cuthbert Dukes from St. Mark's Hospital famously described the Duke staging, Duke's A, B, and C staging in rectal cancer in 1932, based on two key pathological features, which I'm sure you're all very familiar with. So the depth of tumor invasion, so how deep does the tumor invade into the bowel wall, and whether into the connective tissue around the bowel, and also whether the regional lymph nodes, the lymph node that's been cut out during surgery, whether any of those has been involved with cancer. So he's observed that survival is distinctly very different between patients with lymph node involvement, as well as a tumor that's invaded very deep into the muscular layer and serosa of the bowel cancer tissue. Now, 90 years later, despite younger and better looking pathologists and fancier equipment, our basic staging system and how we select our patients for adjuvant therapy in colon cancer remains the same. The depth of tumor invasion, your T stage, and regional lymph node involvement, your N stage. And of course, there are other minor pathological risk features. I've listed some of them there that could further refine the risk, but there is still much uncertainty for the individual patient that is in front of me in the clinic as to their risk, the actual risk of cancer recurrence, and whether we need to give them chemotherapy or not. So this really leads us to the challenges that we face currently in the clinic, where patient selection for adjuvant therapy based on pathological staging alone is imprecise. So I just want to give you an example, because the study we're doing is on stage 2 colon cancer. So I'll give you an example on stage 2. So only up to 4 in 100 patients with stage 2 colon cancer that I treat benefit from adjuvant chemotherapy. In other words, for every 100 stage 2 colon cancer patients that I treat, only up to 4 will benefit. So these are patients with minimal residual disease that are chemosensitive. But the majority are exposed to unnecessary or ineffective treatment. And this is because majority of them, over 80%, are actually cured by surgery alone. And of those who, so they don't have MRD, so of those who relapse despite chemotherapy, they have chemo-resistant disease. So that's a minority of them, but we think it's about 10, 15, 18% of them have MRD by chemo-resistant. So what have clinicians and researchers done over the years to try and improve outcome for patients with stage 2 colon cancer, given the imprecision that we face? So there have been the use of, as you know, in stage 3 colon cancer, the use of K-pox or FOLFOX, the addition of oxaliplatin has been proven to be beneficial and to improve cure rate and survival. Similarly, in the MOSAIC study, there's a cohort of stage 2 colon cancer patient. Unfortunately, despite a small gap between the disease-free survival curve, they unfortunately did not, the addition of oxaliplatin to 5FU did not result in overall survival benefit. So this is the disease-free survival curve, which means really the risk of, the proportion of patient who's alive and disease-free over time seem to be slightly better with the oxaliplatin arm, which is the yellow arm, but it's not statistically significant. Unfortunately, though, if you look at the overall survival, the proportion of patients being alive, irrespective of disease status being alive, there's no difference. Now, why is that? It's because if you do relapse, your survival is a lot worse if you had adjuvant FOLFOX compared to if you had adjuvant 5FU alone. So this is the post-recurrent survival. So what does your survival look like after you've had relapse? So the yellow curve, the patient who had oxaliplatin initially, and the blue curve is the one that had 5FU alone. So survival's worse after you've had recurrence because perhaps these are selecting for patients who had chemo-resistant disease. So I think the key is that there's no overall survival benefit with the addition of oxaliplatin, which is somewhat disappointing as oncologists not to be able to extrapolate the data from stage 3 into stage 2. Now, research also look at better risk stratification, look at other biomarkers, so like the Oncotype DX breast cancer, there's also equivalent in colon cancer, the 12 gene recurrence score. There's also the Oncotype DX colon cancer. There's also, as you know, immunoscore and tumor burden are all prognostic factors that each of them have individually shown some prognostic significance, but unfortunately the hazard ratios are quite modest. The separation of the curve are not very big, and so it's variably incorporated into guidelines to guide adjuvant chemotherapy. And importantly, as Manju has mentioned before, there has not been any randomized trial data to see whether using these tests versus not using them will lead to better outcome for patients. Now let's look at what the guidelines say. This is NCCN guidelines. I'm sure most of you will be very familiar. Now the guidelines currently suggest, obviously, I think if you have deficient mismatch repair protein, they don't tend to benefit from adjuvant chemotherapy. That's the group that is only group that it's been recommended to have undergo surveillance only without adjuvant chemotherapy. But there's several options that could be considered and discussed with patient if you have a proficient mismatch repair, stage 2 colon cancer. So for lower risk disease, so if you have T3 and T3 stage 2 colon cancer without any other risk feature, you can either have surveillance, or you can consider single agent fluoropyrimidine, so capecitabine or 5-fluorouracil. But if you have any risk features, or if you have T4 cancer, then options of adding oxaliplatin could also be discussed. Now, it's important to look at the footnote in the NCCN guideline, where it's basically, it highlights the modest benefit, as I mentioned before, of adjuvant chemotherapy does not improve survival by more than 5%. So currently guidelines suggest that we discuss adjuvant chemotherapy in patients with high-risk features. However, it did also say that in patients with high-risk stage 2 colon cancer, there are currently no data that correlate the risk feature and the selection of chemotherapy, i.e. highlighting the fact that just because you might have slightly bad biology, so prognostic, it does not mean you'll benefit from chemotherapy, so it's not predictive of benefit from chemotherapy. It also mentioned that there's no survival benefit with adding oxaliplatin to 5FU in stage 2 colon cancer. Now, in addition to all the challenges that I've mentioned before, another challenge in bowel cancer in general in early stage disease, unlike our lung cancer and breast cancer, which I'm very envious of my colleague, where they can, many of their drugs that have shown efficacy in the metastatic setting, they have managed to show efficacy in the adjuvant and early stage setting. And so they've got more and more new drugs developed in the early stage setting. But in bowel cancer, despite 8 randomized trial and nearly 15,000 patients, trying to bring all the active agents in the stage 4 setting forward, none of them have been shown to be of benefit beyond 5FU and oxaliplatin in the last 18 years. So really questioning how we should be developing new therapy using the old model of a clinical trial infrastructure. So I think the lack of enrichment to be able to pick really high-risk patients to develop new therapy potentially could dilute the efficacy signal in a subgroup which may benefit. from patient, and this together with the lack of early marker of adjuvant treatment efficacy. So currently, we don't have any way of measuring how effective the chemotherapy has been in real time. We often have to wait for several years to see whether the patient recur, or for survival data, be able to infer whether the adjuvant treatment will work. So the current system really, based on the infrastructure that's developed over 40 years ago, can't really easily handle some of the challenges of developing many new therapy concurrently. And this is of particular relevance for the early stage disease, where the risk of cancer recurrence is low-ish, and therefore there's low event rate, so low recurrence or low death rate, and adjuvant trial will therefore require a large number of patients over a long period of time to capture these events. So how do we move the field forward? I think what we need is a biomarker MRD clearly, a robust biomarker that could accurately predict for recurrence and tell us who will require further treatment and who can be spared potentially toxic treatment. Incorporate biomarker that could provide an early readout of the adjuvant treatment efficacy, with the potential to introduce some additional novel therapy to salvage these patients if they still have CtDNA or still have MRD positivity after their standard care chemotherapy. So this really brings me to the topic of circulating tumor DNA, which I'm sure most of you are aware, but for the benefit of those who are not familiar with this concept, I'll just go through very, very briefly. So circulating cell-free DNA, which was first described in 1948, really refers to a small DNA fragments found in the cell-free component of the whole blood. And in healthy individuals, we do have cell-free DNA floating around, and this is mainly derived from hematopoietic cells, so cells coming from the bone marrow, and it's usually found at a very low level. However, in patients with cancer, a proportion of these fragmented DNA is derived from the tumor cell itself, and this is called circulating tumor DNA. The clearance of cell-free DNA, which is predominantly in the liver, is very rapid, so with a half-life of only 2 hours, which is a very attractive feature compared to half-life of about 7 days with CEA, and obviously with imaging, it takes a lot longer for it to declare itself in terms of the assessment of the tumor burden. And one of the most appealing features of ctDNA as a cancer marker is their exquisite specificity, where cancer-specific genetic changes or epigenetic changes of methylation marker or DNA mutation can be used to distinguish cancer-derived DNA from other normal cell-derived DNA or other cell-free DNA. So really with the advancement of ctDNA detection technology over the past decade, we now have the capability of detecting these tumor-derived DNA in the blood and the circulation at a very, very minute level, very low level, which is what we will need for MRD detection. So the broad concept really is that after surgery or any curative intent treatment, could be chemoradiation if that's the form of curative intent treatment, you take the blood of the patient, and if you detect tumor DNA in the patient's blood after curative intent treatment, that indicates you still have residual cancer left behind, and predicts for very high risk of recurrence if the patient does not undergo any further treatment. If there's no tumor DNA being detected, then there's a low chance of patient having minimal residual disease and therefore a lower risk of recurrence. So this is the first study that was published by the Johns Hopkins group back in 2008 in Nature Medicine, work led by Luis Diaz and Frank Deal, where they actually took serial blood of 18 patients with colorectal liver metastases, where when they collect a pre-op sample and then post-op sample and serially during surveillance. So these are patients with colorectal cancer and liver metastases, and then they undergo surgery to resect all visible cancer. As you know, with patients with colorectal liver metastases, a proportion of them can be cured by surgery alone, and then they follow them up through. So I'll just give you an example of the result of one of the patients. So this is using the beaming assay. This is quite an old assay now. So The green dots are the flow cytometry data. The green dot indicates normal DNA, and the red dots indicate cancer-derived, so APC mutation, APC as a tumor-derived DNA. So before surgery, you can see there's a lot of cancer DNA in the patient's circulation, and day 3 post-op disappeared. You can't really see much, although I think this is the quantification, is very low level still present. And over time, you can see the red dots starting to get more and more of them. And obviously the level increases over time up to the time of cancer recurrence. So this was the data really that inspired us to take it forward in early stage colon cancer. So we thought we started off with stage 2 colon cancer because we feel that is the greatest clinical need at that time, because adjuvant chemotherapy is really, the benefit is so modest that we're over-treating a significant number of patients. So we undertook a study where there's about roughly about 250 colon cancer patients. A proportion of them were treated with adjuvant chemotherapy, and significant proportion of them were not treated with adjuvant chemotherapy, and therefore we could actually assess the prognostic impact of this marker accurately. So what we did was we collected serial blood of these patients. Once again, we measured ctDNA, and then we followed them up, and we didn't intervene. We just simply wanted to see whether the detection of ctDNA after surgery could correlate with outcome. And we took blood about 4 to 10 weeks after surgery. So shown here is the survival curve of a group of stage 2 colon cancer who did not undergo adjuvant chemotherapy. As you can see, there's a huge separation between the curve. About 80% of patients who had ctDNA detection 4 to 10 weeks after surgery had all recurred at the time of their last follow-up, compared to only 10% of them who did not have ctDNA detected after surgery. So a huge difference in terms of outcome between the two groups. We've subsequently also did study in stage 3 colon cancer and in rectal cancer. So stage 3 colon cancer, now unfortunately, majority of patients undergo adjuvant chemotherapy. In fact, in our study, all the patients undergo adjuvant chemotherapy over time. So that's why the curve is not separating as big as a huge gap as the stage 2 colon cancer. This is a no chemo group, and this is the chemo group. So take into account of the effect of the chemotherapy as well on the ctDNA positive patients. So, but despite receiving adjuvant chemotherapy, patient with ctDNA positive disease still don't do as well as patient with negative disease. But this suggests that there may be some benefit of adjuvant chemotherapy to stage 2, in the stage 3 disease after chemotherapy, because we'd assume potentially without chemotherapy, the survival could probably sort of trend down here. Similarly, we've done a study in locally advanced rectal cancer. We took post-op blood as well and showed that once again replicate the prognostic impact of a post-op ctDNA detection in terms of predicting for recurrence. So moving beyond post-op, the other applicability of ctDNA obviously is looking at the dynamics over time, particularly after adjuvant chemodynamics, to assess if patients have benefited from adjuvant chemotherapy. So potential scenario would be one where they initially have ctDNA detected, become somewhat, often they drop with chemotherapy, but really persisted the ctDNA detection, and it continues to rise during surveillance up to time of imaging, suggesting that the chemotherapy is not effective in eradicating cancer. And an alternative scenario is the patient with a detectable ctDNA, which remain undetectable over time, and therefore suggests that the adjuvant chemotherapy has been effective. So it's really a surrogate marker of adjuvant treatment efficacy. However, not everyone's biology is the same, and the trajectory of a ctDNA rise may also be very different. So if you compare there's two patients' trajectory, this patient's lead time from ctDNA detection to imaging detection is a lot shorter than this patient's lead time, suggesting that this patient potentially have a much bigger window for opportunity for us to intervene with novel therapy. So assay sensitivity, therefore, is very important. So if you have an assay that can only detect ctDNA at this level, you have much shorter lead time for intervening, whereas you have a assay with a much higher sensitivity, you're likely to have a much longer lead time for us to intervene with novel therapy or even with adjuvant chemotherapy to impart cure. So this, I just want to show you some anecdotal example from a stage 2 colon cancer study that I've mentioned previously. We collected serial sample of patients who received adjuvant chemotherapy. So these are 2 patients where their ctDNA was positive and then became negative and remained undetectable during surveillance. And these patients are lightly cured, and we think they have chemosensitive disease. Whereas in the contrary, we have data from another 2 patients where the ctDNA was positive initially and remained positive either at the end of chemotherapy or during surveillance, and continue to rise up to the time of clinical recurrence, suggesting that they have chemo-resistant disease. So there's 2 important points, even though these are just anecdotal examples. 2 important points from these data is that potentially chemotherapy can cure patients with ctDNA positive disease, like these 2 patients, and the fact that ctDNA can be used to monitor the usefulness or the efficacy of adjuvant chemotherapy in real time, much earlier than what we could tell from clinical imaging. So this is data from the Japanese study using Signatera assay that was presented at ASCO earlier this year. This is also an observational study, so the Galaxy study. They also, what they did was they look at patient who was ctDNA positive, whether they were treated with chemotherapy or not. And this gives an indication that, once again, that maybe adjuvant chemotherapy will be curing a proportion of patients with ctDNA positive disease. So the outcome of ctDNA positive disease who did not undergo adjuvant chemotherapy compared to those who underwent adjuvant chemotherapy. Now, the caveat is that the median follow-up is relatively short for adjuvant studies, less than 12 months. So we would interpret this data with caution, but there's certainly at this stage some early suggestion that the 12 months DFS is almost doubled in both the stage 2 and stage 3 disease between a group that had chemotherapy versus who didn't. So this is observational data only, but it's encouraging to see. So this really brings me to the Dynamics study, which is the world first study that looked at using ctDNA to guide therapy. Now, there are many ways to skin a cat. You're probably aware of many other ctDNA guided studies or clinical trials around the world at the moment. What we've decided to do is do a strategy trial, because we believe that it's such a clinical predicament in the clinic at the moment to know who to give adjuvant chemotherapy to. So we wanted to see if using ctDNA blood test to guide therapy could reduce the use of adjuvant chemotherapy, but not compromise the risk of cancer recurrence. So how do we answer that question? So this is dynamic trial design. What we did was we enroll 455 patients with stage 2 colon cancer across 23 Australian centres. They had each patient had a blood test at week 4 and 7 after surgery. And then patients were randomized to 2 groups in a 2-to-1 ratio. The ctDNA guided group, where patient with a positive ctDNA result at either week 4 or 7 underwent adjuvant chemotherapy. The regimen, either 5-FU or FOLFOX chemotherapy or CAPOX chemotherapy, is at clinician's discretion after discussion with the patient. Whereas those with a negative result at both time points, they were just surveyed, they underwent surveillance without any adjuvant chemotherapy. Now, the control arm is a standard management arm. Essentially, clinicians will decide, looking at the patient's conventional pathological criteria and after discussion with the patient, what they would be offering the patient. The regimen, as well as whether they have chemotherapy or not, will be completely at clinician's discretion. So what did we look for? The 2 primary endpoints that we look for were the use of adjuvant chemotherapy, the percentage of patients who receive adjuvant chemotherapy in the 2 groups, as well as the proportion of patients who's alive and remain cancer-free at 2 years after surgery. I just want to make just want to go through very briefly about the CtDNA assay that we use. So all the blood tests were done in a central laboratory at Johns Hopkins. It's a research grade assay, not a commercial assay at this stage. We use a tumor-informed approach. So essentially, it means that we sequence a patient's cancer, the cancer tissue that was resected first, and we identify at least one mutation in the patient's tumor tissue. And a CtDNA assay was then designed specifically based on the mutation profile or the individual patient's tumor tissue. So it's a bespoke assay. So we look for mutation that was identified in patient's tumor tissue in the patient's blood that was taken at week 4 and 7 concurrently using the SAFE-seq assay, which is a assay that's that was designed specifically to detect MRD. So what are the main study results? What we found was that there's less patient, a lower proportion of patient, 15%, received adjuvant chemotherapy in the CtDNA group compared to the standard care group. So CtDNA guided strategy almost halved the number of patients who received adjuvant chemotherapy after surgery. And the number of patients or proportion of patients alive and cancer-free at 2 years are 94% in the CtDNA group compared to 92%. So the chance of being alive and cancer-free at 2 years is comparable between the two groups. We then also we were really interested in to see what the outcome of the patient in the CtDNA guided group, according to what their CtDNA result is. So what is the outcome of CtDNA negative patient who were not treated with adjuvant chemotherapy? The chance of being alive and cancer-free at 3 years is 92.5%. And in the CtDNA positive group, what happened to them after they received adjuvant chemotherapy? They don't seem to do as well as CtDNA negative group, perhaps not surprising, 86.4% proportion of being alive and cancer-free. But you have to remember, without treatment, historically, these patients, the chance of being alive and cancer-free at 3 years is roughly only 20%. So I think there's significant benefit, potentially in CtDNA positive group who receive adjuvant chemotherapy. So the take home really for the dynamic study is that for stage 2 colon cancer patient, a CtDNA guided approach of treating only those with a positive result after surgery compared to our current standard care on not using the blood test substantially reduced the proportion of patients receiving adjuvant chemotherapy but did not worsen the risk of cancer recurrence, thereby allowing more precise prediction of relapse and patient selection for post-surgery therapy. So the CtDNA blood test can help, and additionally to help identify a patient at very high risk of cancer recurrence, which are your positive patient if not treated with adjuvant chemotherapy, and those with a very low risk of recurrence who are very unlikely to benefit from adjuvant chemotherapy. So where to from here? We also collected blood tests of the patient who was CtDNA positive and received adjuvant chemotherapy. So the dynamics of CtDNA and the correlation with CEA, and also correlation with the sites of recurrence, distant recurrence versus local regional recurrence, will be presented at ESMO next month. So watch the space for that. We will have 5-year overall survival data, which I think most will be very interested in late 2024, and hopefully will be presented in another major meeting. We also have several interesting sub-studies. We have some fear of cancer recurrence sub-studies. We want to investigate if knowing the results of your CtDNA compared to not knowing it will reduce your fear of cancer recurrence. So that's work that's ongoing at the moment. We also will be, one of my PhD students, looking at health economic analysis to see whether using CtDNA guided treatment will save costs in general, healthcare costs in general. We're also looking at, so similar to immunoscores and immunoinfiltrate in the tumor tissue to correlate CtDNA. Obviously, many other ongoing trials. You have the COBRA study, which is run in Canada as well as in the US, that will provide hopefully further evidence of the benefit of adjuvant chemotherapy in the CtDNA positive patients. There are other ongoing randomized trials, such as the Dynamic 3 trial and other trials in stage 3 colon cancer over the internationally, that will provide further evidence of utility in colon cancer. So just very quickly, this is the Dynamic 3 study design. So this is a AJCC sponsored study. We also have the pleasure of the Canadian trials group joining us last year. So this trial is now over 80% recruited of the 1,000 patients that we intended for recruitment. Once again, is looking at whether we can use ctDNA to guide therapy. So we have the standard of care arm, B, where the clinician decides whether they will give patient chemotherapy and whether they'll be giving adjuvant single agent or oxaliplatin 3 months versus 6 months. But importantly, the patient has to declare what the intention is prior to the patient being randomized. So in the ctDNA informed arm, the patient with a negative result will have a less intensive treatment. So that could be either duration being shortened or the intensity go from doublet to single agent chemotherapy. In the positive group, patient will receive a more intensive treatment compared to what the clinician initially intended to do. So that's the study hopefully will finish recruitment next year. So finally, I just really want to talk about the concept of post-chemotherapy ctDNA. So I've also mentioned previously, as you know, that the CtDNA Dynamics can predict for efficacy of chemotherapy. So we've collected blood of patients after they finish adjuvant chemotherapy in our old observational study and have shown that truly that predict for recurrence in the group of patients where their ctDNA remain positive after surgery compared to the group that ctDNA is negative, sorry, after chemotherapy, not after surgery. So this is resected stage 4 colon cancer, or patients who had a positive ctDNA after adjuvant chemotherapy recurred, compared to just about 70% of those who cleared their ctDNA after chemotherapy, suggesting that ctDNA status post-treatment, post-adjuvant chemotherapy could also potentially be used to enrich patients for novel therapies. So there's a lot of excitement in this field. These are just some selected trials that's using ctDNA status after their finished adjuvant treatment to enrich for patients to explore the efficacy of novel therapy. So I call it a second line or standard adjuvant therapy. So a lot of these studies are ongoing currently in the US. Act 3 is only led by Panna Parikh from Massachusetts General Hospital. That's a basket study, really. If a patient have a molecular target for target therapy, they'll undergo target treatment. Those without any a molecular target will undergo second line adjuvant for FERI versus surveillance. Altair is a Japanese study looking at long-serve as the novel agent, following 3 months of adjuvant K-pox if they're still ctDNA positive. Obviously, there are other vaccine study, mRNA vaccine study, I believe from Emily Anderson, and some peptide vaccine with nivolumab across stage 2, 3, and resected stage 4 cancer. And this is a very interesting study as well, looking at lifestyle changes in aspirin in patients who are ctDNA positive after adjuvant chemotherapy, and see whether they could clear the ctDNA with aspirin and vitamin D. So I just really want to acknowledge a whole lot of people. Some of them I can't even fit onto the slides. There's really the patients, the caregiver, all the investigators that's been doing all the study, not just in Australia, but around the world, to really trying to move the field forward in the early stage colon cancer space. I particularly want to thank the sponsor and my project team in the Walter Eliza Hall over the last 10 to 12 years of hard work in bring it really from an observational study now to potential practice-changing trial. Obviously, my long-term collaborators at Johns Hopkins, who provided all the molecular expertise for our study, and the many funding bodies that allows this work to continue, and many of the participating sites. These are just the 23 sites participating in the stage 2 study, but we have now about 43 sites participating in Dynamic 3, as well as over 20 sites in Canada for Dynamic 3, which I'm very grateful for their support. So I'll end my talk there and happy to take any questions.
Yeah, Dr. T, thank you for that excellent talk. So we can go through the chat for questions. Let's look at the questions in chat.
The data seems to show that CtDNA is likely to show a recurrence. My oncologist says the test is not fully accurate and can identify things as cancer that are not. But then she said it is 80% accurate, which I think is higher than the alternative CEA. She said that even though I've had 3 positive Signera tests with small number under 1. Yeah, I'm not sure. Small number. She can't do anything if she can't measure the effect of chemotherapy. So my questions are, how accurate do you think these CtDNA tests are in detecting a recurrence? Does the number of CtDNA residual equate with how fast it is growing? Very good question. So no test is 100% accurate. As you can see from our study, you know, that the CtDNA negative group, the recurrence-free survival is 93% or so, and that includes death from other source, not just cancer recurrence. So the recurrence rate is actually lower than that. I think the recurrence rate for a CtDNA negative group it's more about 5 or 6% at 2 to 3 years. Obviously, we need to wait for a longer follow-up, so it's really quite low. So, but there is a bit of false negative, I suppose I would call it. And these tend to be local recurrence. You probably see from our ESMO data where we look at the correlation of site recurrence and ctDNA. Probably about half the negative group are local regional recurrence. So we have anastomotic recurrence or peritoneal recurrence. We tend to be less sensitive because they're not in the circulation, they're in transluminal in the intraperitoneal region. And the other group that we can tend to miss initially is your very small lung metastases, sub-centimeter lung lesions that those tend to be missed at the initial time point. I think the important question is if we keep following them up over time, will that increase? Now, the assay that we use is quite an old assay now. The dynamic study started 6-7 years ago. So we've now improved the assay significantly. So there's a new generation of assay out there. Whether that would improve the sensitivity, that's obviously a separate question. Now, it says identify things as cancer that is not. Now, that is really only applicable to tests that doesn't use germline DNA as a control. So that is predominantly a problem for non-tumor informed tests or assay that doesn't use whole blood or normal DNA as a control. If you use a tumor informed test where you actually genotype the tumor and then you pick the tumors and mutation to follow, as well as use whole blood as a control, it is very specific. So I don't think you pick up any what we call CHIP. So that's where the conohematopoiesis of an origin or indeterminate significance. That can be a problem because there's this low-level mutation, particularly in elderly patient or patient with smoker or previously had chemotherapy, can have this very low-level non-specific mutation. But if you use whole blood, patient's whole blood as a control, you can filter those out. So I think it can be highly specific, provided using the right test. So the question, which I think there is a group of patients where there's very, very low level of ctDNA that the immune system, your body can clear it itself. It doesn't mean there's no microscopic disease. The patient may not recur, such as breast cancer patient, for example. Some of them have 10 years before they recur, some don't. I do believe that there's probably a bit of immune clearance going on in this in a small proportion of patient, very small proportion of patient, especially in a very, very low level. So the question about the level of ctDNA, I think the level does reflect how much microscopic disease you have if you have a very low level. Now, I don't know what one equates to from the Signatera assay. Is it 1% or is it 1 mutant molecule? It probably means 1 mutant molecule. That's pretty low. Yeah, that is pretty low. If you monitor over time, then and it's truly cancer recurrence, they will actually increase over time. If they don't increase over time, if it just remains at low level at 1, and you keep doing every 3 months, 6 months ago, they still remain at 1. That indicates to me then, and you do scans, PET scan, and you don't find anything, then maybe that could be non-specific. And in Signatera, I believe, is a tumor-informed assay. They also use whole blood. So in that scenario, I don't know. Yeah, I wouldn't. That would be hard to explain. Whether the immune system is keeping something in check, it's hard to know. But generally speaking, much like CEA, it should go up with time. If it's, as I've shown in some of the example, that they do rise with time. I hope they've answered that question. Does the number, yeah, so it does, yeah, it does equate. That one snapshot, you can't tell how fast they're going to grow, but obviously serial sampling and the level over time will give you an indication how fast it's growing. That just be months or year between. Yes, that's right. The lead time, didn't really go into it. The lead time for majority of patients is about 6 months. So between a positive test and recurrence, so they're pretty quick. So the window of opportunity to intervene is actually not years. It's small. And that's why post-op, I think that's why post-op, I think is the best time to intervene. And if you were to omit treatment and trying to do serial testing, I think 3 monthly may be a bit too infrequent initially if you were not to give chemotherapy, particularly given that the recurrence, most of the recurrence happen in the first 6 months. I would say you probably need to do more frequent monitoring initially. And you can do less frequent down the track, but certainly in the first 6 months or even 12 months, doing much more frequently than 3 monthly, like what we currently do for CEA.
I think maybe she's talking about clearing MRD. What should they do to clear MRD? Would you suggest trials?
Yeah, definitely trials. Because, so one of the big things we don't know is once you finish your adjuvant chemotherapy and you see the CtDNA positive, we don't know whether any further treatment is going to be beneficial for these patients. And we don't know what treatment. So the only way to get it, to move the field forward to get definitive answer will be to go on a trial. And I've had questions about those before. You know, I finished chemotherapy, but I've still got MRD, done PET scan, done everything, couldn't find anything. What should I do? You know, would you be giving FOLFIRI to these patients? We don't know that, and you've got, we don't know that's going to be of benefit. I think if we start doing random things, we will never move the field forward. So go on to a trial. There are many trials now in the adjuvant setting, in the MRD positive setting. Find a trial and go on to it if you can. It's my pro trial. That's the only way we can get definitive answer. Yeah. Are patients in Australia or New Zealand able to access CtDNA testing outside of trials? We don't have MRD assays in Australia or New Zealand at the moment. If we do want to access them, we do have to send the test to the US. So you are very lucky in the US that you actually have commercial tests available. We don't have at the moment. Hopefully in the near future, when there's more and the Hopkins group are commercializing their tests, we may be able to access them. So that's one of the advantages, I guess, is that because they can't access them, and also there's no funding for them, the healthcare model is quite different between Australia and New Zealand and in the US. The private insurance don't usually fund these blood tests, so usually it's through government funding, very similar to the Canadian model. So patients, in order to access this, that they have to participate in the trial. So that's potentially one of the reasons why we do recruit quite well. A small population, but we do recruit quite well to these trials because they can't access them off trial. And because, as you know, a group of patients are blinded to the results, so no one really wants to be blinded to the result, generally speaking, if you have access to the trial. It was 0.4, then how, and now at 9 months it is 0.9. That's why I was asking. Oh, sorry. That was was it about, is that the level of
the
this?
same person? Yeah.
Is that the level?
Like,
yeah, it's a 0.4. Oh, so it seems to be going up. And I assume the scan is negative still. And this is have you had adjuvant chemotherapy, or you finished your adjuvant chemotherapy and you're currently doing surveillance? Do you have access to a clinical trial? There are other trials, like the vaccine trials as well, looking, I don't know when they enroll patients, but they're all looking at a range of stages with positive CtDNA after adjuvant chemotherapy. It is an important question because, you know, do you give FOLFIRI now in your situation, or you just keep watching it? We don't know if having FOLFIRI now will be beneficial. Will do anything. We don't know, simply don't know. And I think going onto our trial is probably the best, will be my recommendation if you can get onto one. And outside of clinical trial, I probably wouldn't be doing anything and just be monitoring.
Okay. Dr. T, I had a question. So I really liked your introduction and, you know, your thoughts on like being able to find a population to do trials using ctDNA, and then using ctDNA as a way to monitor responses. So I'm kind of curious, you know, I really love that you started a trial instead of like, you know, you want to look at it systematically. So I was kind of thinking for future directions, do you have studies planned where you're taking a ctDNA positive population and then trying to test novel therapies? Like, what is in your head? Like, what are your future plans, like broadly?
Yes, that is one of the what I really want to do is similar to a panaparixis trial, a basket trial, where patient who remain positive after adjuvant chemotherapy, we then explore novel therapy, because that's really, I think, a group where we can improve outcome. And similarly in stage 3, I think there's not sufficient data. I'm certainly quite comfortable, particularly in low risk stage 3, to not give chemotherapy and watch them over time. I think that the unanswered question really is, if you don't give chemotherapy initially at the 4-6 weeks mark when you do a blood test, and you keep monitoring them monthly, if at some point they do come up positive, and we give them chemotherapy, so slightly delay chemotherapy, whether you can still salvage the patient. So I think CtDNA really opened up a whole new field. We tend to always think you have to give chemotherapy within 8 weeks after surgery, otherwise you can't salvage this patient anymore. That's not the case. I mean, we've shown in our stage 2 study, most of our patients only started chemotherapy at week 12, and majority of them were salvaged. The question is whether if we start early, it could be even salvageable, but I think with the testing and things like that, and the turnaround time, that maybe not realistic. So I think that there's a number of questions that's unanswered, and future trials, including the Circulate US and Japan, will answer is if you don't give chemotherapy negative initially, but become positive during surveillance over time, can you still salvage them? And then the question is, when you salvage them with normal adjuvant chemotherapy, if you're resistant, what else can you do for this patient? Is giving chemotherapy early in microscopic disease setting better than just surveillance, not doing anything? That remains unanswered, and we need to answer that question. And I'm thinking the basket trial, it's a numbers game. It's quite hard to recruit because there are not that many patients that has MRD and then remain MRD positive after adjuvant chemotherapy. I think it's just get smaller and smaller population. And then if you're looking at targeted therapy, how common is BRAF mutation? Not that common. MSI high, not that common. I think the group that possibly we may get answer is, your non-targeted group, vaccine, your FOLFIRI. I think even though FOLFIRI has not shown adjuvant benefit in adjuvant in the old study, those are unselected patients, right? So we know that some patients in this metastatic setting, they're resistant to FOLFOX, they can still respond to FOLFIRI. So I'm pretty sure they're probably a group of patients that may benefit. We just haven't picked the right patient because we didn't, until now, didn't have a marker we can follow. So I think it should be explored again. A lot of patients, why do you give FOLFIRI in your study design MRD positive when the trials show negative? Well, I think it's a different question really now we're asking. We're looking at patients who are resistant to FOLFOX and then give FOLFIRI, right? So basket trial, I think, is the way to go. And I also think there should be international collaboration more of that. I think this is tricky because there's so many different assays. Everyone's using different assays. Everyone's got different ideas of how a trial should run. But hopefully we will all individually run our trial, but we can still combine the data ultimately to get more power and answer some of the more niche question with smaller subgroups of patients. Yeah,
and also like in general, for us, like similar to Dee's case. So what in the groups we recommend is to have a second look. Say, for example, do an MRI and see if you can detect something in the liver, or have a laparoscopic look at the peritoneum or something like that. So it'd be kind of nice to know, have a trial which looks at when somebody's MRD positive. Maybe your data that's coming out in ESMO, maybe you have that answer. Like where exactly is it coming up, and can you do local therapies? Like instead of FOLFIRI, can you do a liver resection if it's coming up in the liver?
Yeah. They're very good question, because a lot of our patients could be salvaged by more surgery. They don't need, so quite a few local recurrence that we missed. The CtDNA negative group, they had local surgery, they salvaged that from there. And even the distant recurrence, they had liver met that was picked up at imaging, that was salvaged by liver surgery as well. So this is not during surveillance, this is the initial CtDNA negative group. So standard care wise, I think if you're CtDNA positive, that is absolutely the right thing to do. Is just keep looking, scope. So your second primary or recurrence of the initial primary. So I would say repeat your colonoscopy, do a PET, do an MRI, do a CT. Do you do a laparoscopy looking at peritoneal disease? You could, but I'm not sure they could see just with laparoscopy, particularly if you've had surgery before, how well they could see it. You could do that if there's a facility to do that, and look for everything to see whether there's anything resectable. If not, then just keep monitoring, because I don't know that we should be giving chemotherapy at this stage. We haven't got evidence, and then you burn through all your treatment option.
Yeah, we have one last question, and I think we're past. Do you have time? We could.
Yes.
So it's basically about the site of recurrence for stage 4, sensitivity of CtDNA to detect it based on the site of recurrence.
Yes, we don't know where they're going to recur. That's the problem ahead of time, right? That is one of the problems. If I knew a patient's going to recur in a local regional area, maybe then I won't be using CtDNA. So one of the difficulties that we don't know upfront. Your T4 patient may be more likely to recur locally. So those ones you may, they also recur distally as well. So if they're CtDNA negative, a stage T4 cancer or T4N1 or T4N0, CtDNA negative, what do you do in that situation? It's a difficult one, because I don't know, at this stage we don't have definitive evidence that systemic chemotherapy actually reduces recurrence locally. We know they reduce distal recurrence, makes sense. Does it, if a CtDNA negative patient, majority of them recur locally, especially a T4, does giving chemotherapy to these patients, will they improve outcome? Will they reduce local recurrence? That we don't know, because it's local disease, and we think that local therapy is probably more effective than systemic treatment, right? So that's a question I think it's remain unanswered. Just because you're negative does not mean that having chemotherapy is going to improve your outcome. And at the beginning, we in a post-op setting, really until patient relapse, we don't really know where they're going to relapse. So that is a tricky one.
Yeah, I think that like there are some methylation markers which are organ specific, some epigenetic markers. I think something is coming up like in other cancers.
Yeah, organ of origin, methylation, but they have to be positive, right? That's ctDNA. They have to be detectable, then you know where they are. If they're negative, you can't detect them in the circulation, then you can't tell, right? Unless there is other features in the radiology, or the they're perforated, for example, and you're really concerned. Those ones, maybe ctDNA not so good at predicting their local recurrence. So maybe other risk features we have to take into account. Yeah.
Okay.
We'll present our data at ESMO.
Excellent.
But so basically local recurrence, predominantly the negative group. Yeah. And quite a few of them are salvaged by more further surgery.
Which is kind of nice to know. So ctDNA being a predictor of like more distant disease than local. Yeah. Wow.
Yeah. And hence my comment about systemic chemo. Yes, they're negative. They call it false negative, but does it really work in preventing local recurrence? Is it still safe to omit chemotherapy in this patient? That is an unknown. But it's reassuring their local recurrence. That said, there are a few particularly small lung mets that was missed initially, but the Japanese data, all retrospective, they compare a group of patients with negative chemo versus no chemo, it's shown no difference. So whether you receive chemotherapy or not, if you're CtDNA negative, it shows no difference in outcome. But that's retrospective data, early short follow-up. But that's a big question. You're negative, but does chemotherapy actually improve your outcome if you're negative? That may be a group that doesn't benefit.
Yeah. I mean, the fact of, I mean, I don't want to press you on the data because it's going to come out next month. So we will with lots of interest watch out for that. And I mean, you saying that is very reassuring, because then, especially for colon cancer, if the recurrence is mostly local, then there is no point in getting chemo upfront, to kind of stave off that, the chance of recurring, because you could have surgery if it comes back locally, right?
Yeah, so the negative group comes back locally, but the positive group are mainly distal.
Yes.
Yeah, okay. So the positive group really needs chemo, yeah?
Yes.
So the positive group, so basically ctDNA positivity predicts for distant recurrence rather than local recurrence, whereas a negative group tend to be more local recurrence. So if you're positive, so the important message is that if you're really trying to pick those who would likely relapse distally and therefore may benefit from adjuvant chemotherapy. So the positive group do mostly relapse distally.
Okay. Yeah. Okay. But that's great information, right?
Yes.
That's so important to know. Yeah. Okay. Yeah. Thank you so much. And this is great. And have a great day ahead.
Thank you for the invitation. Hope it's helpful.
You're very welcome. Bye. Yeah. Okay. Thanks. Bye. Thank you all for attending.